왜 시작 안 해요?
아,
아무도 없어요?
오디오가 안 되고 있었던 것 같은데.
아, 계속 하고 있으세요?
응?
지금 오디오가 꺼져 있었던.
됐어요?
네, 되고 있습니다.
Okay. Please summarize what we discussed.
Okay, so I will introduce myself. Second year fellow, Seong Chang, and I'm going to present today's case. And we are discussing this case. This patient has tachycardia of 100 to 120 and normal axis, and we can see the P wave and QRS complex associated, but we are not sure about the T wave alterance. In here goes up and goes down, and also the RR interval doesn't seem completely regular. And we are not sure about this rhythm. It seems like incomplete RPBB and narrow current complex and two RPBB pattern. And we're still on discussing.
So when is the QT get longer? When the RR interval gets shorter or get longer? Take a look. When RR interval is shorter, right? Because when RR interval longer, T wave is upright. But when the RR interval slightly shorter, T wave will get much longer and inverted. Okay? So this is a rate dependent what? Alternance. That's one conclusion you can draw. Second is that what is the mechanism of aberrancy? If this is aberrancy, if why the RR interval get longer, get right bundle? But it's not much longer. It's not like an Ashman phenomenon. You have long, short sequence, slightly longer. Did that mean anything to you? So this heart rate must be very close to right bundle refractory period of this patient. But heart rate 100, that doesn't really make it too much sense, right? That shows that this patient has also conduction system. And then subsequently shorter, got almost like a fusion, can narrow again, and then disappear. So basically the impression is that this patient does not only have global conduction abnormality, repolarization abnormality, also probably conduction system as well, particularly right bundle.
Is it pathologic anatomical conduction abnormality or physiological?
Physiological.
Because QT is prolonged, and the very long QT make repolarization heterogeneity. Because heart rate is fast, some area of conduction system or his Purkinje junction is refractory period, making incomplete RBBB, correct?
I think this is, you can conclude that Dr. Park says is okay to distress somebody who has an underlying long QT, or could be a normal person with the sort of an external factor prolonging QT plus all those changes. So this is going to be a reversible causes. Or patient has a prior history of long QT syndrome, then not a very good news. Yes. Anyway.
But still, I don't understand why the last two bits in V1 shows the incomplete RBBB consecutively.
Well, yeah, because of I think the slight prolongation RR interval, even that can cause that. But if you look at your first bit V2, V1, that first bit is that the incomplete right bundle narrowish looking. The subsequent one almost become normal. Then the next one becomes a little bit more right bundle pattern appearing, and then become complete right bundle. It's almost somebody would call Wenkiba, but I don't know what the bundle Wenkiba going on there or not. So because RR interval got longer, even became more right bundle. So whether it's a phase dependent phase block, possible, but it's just not. If you don't see any other place, we can just only can speculate.
So I think prolongation is variable.
Yes,
in this situation.
Yes.
If you look at the rhythm 3 B2 lead 2, so in some QRS complex shows wide S wave, some QRS, no S wave. So wide S wave means in the middle of the ECG, right side. Yeah. And next one is no. So next one, little, no, then bigger.
Yeah. So
Right.
this is basically alternation of everything going on. It's very rare to see this type of situation. Usually we see rate dependent or represent dependent in alternates, but not conduction as well as the activation.
Okay, Dr. Daewon Kim, Dr. Hyunjin Park. Please add more interpretation.
I think this is PVC with fusion, but I don't really understand exactly what's going on.
So you think it
Maybe over in C.
what's the evidence of PVC? You agree with coffee?
One argument is that the PR interval, that tribundle, appears a little bit shorter than the narrow complex ones. But subsequent also has a similar PR interval. That would be against the PVC. So there's some reason there's enhanced nodal conduction in that particular 2-bit making cause of bundle aberrancy. It's possible. There is a phenomenon called supernormal conduction. Some people, believe or not, never proven it clinically, but it's an animal model. You can have a supernormal conduction, such a critical alternance cycle length. And that might be what people talk about, but we will never prove it clinically. True, there's a supernormal conduction. Mostly can explain by the gap phenomenon, mostly. The PR interval looks the same, both complex.
If you see in V1, the first,
Mhm.
second, the white QRS complexes differ, like in
Yes.
NP2. So I thought that it would be more likely to explain as different degree of fusion of the PVC rather than different aberrancy.
So aberrancy or PVC? Do we need to vote it?
I'm not sure.
If you look at the lead V3, look at the T wave morphology. First one is very deep inverted T wave, almost overlap with QRS. Next one is upright. And third one is even deeper inverted T wave. So I think that the QT interval is quite variable, and typical T wave alternance. It is, I think, a very dangerous condition, even without PVC. So in the old paper written by Rosenbaum, there's two different kinds of alternance. If the refractory period is increased and heart rate faster, QRS alternance naturally generated. But if it is concordance, long short concordant, at that condition, the VF is very difficult to induce. However, in certain part, there's conduction delay or conduction block and make a discordant alternance. Some part of ventricle is this line, the other part is the opposite side. Then we could localize reentry easily and make a ventricular fibrillation. So that's why the T-wave alternance is dangerous, even without PVC. Okay, any comment, Dr. Kim, Dr. Ong?
I don't have any.
I have no.
엄선생 원장님?
네.
As a primary care EP physician,
So, you know, I don't know whether, you know, in the early reproduction syndrome patients, QT that tends to be shorter, not this long. So this is not the, you know, part of a J-wave syndrome. It's something different, looks like. Unless patient has been receiving drugs or something like that, just change it, but it's not normal. Okay, let's the next slide. Will give us answer maybe.
Okay, so patient was actually
2 year.
Yeah.
Oh.
And in my
Not a stressful condition.
There we go. Don't
if
you
I
take
explain some tachycardia and the short period interval and maybe we want future lecture. Actually, he's actually in the stressful condition because he was under recurrent ICD shocks after with sleep. He was diagnosed as congenital long QT syndrome type 3. He had the aborted sudden cardiac death and he implanted the cardiac ICD implantation. But unfortunately, he experienced some inappropriate and appropriate shocks after the ICD implantation. And he was taking the Nadolor, but it wasn't enough, so we limited the patient and increased the doses with Nadolor and Maxlotin. And this is his EKG. The genital looks very big in his body. And he
Excuse me, can you let me know where's the ICD lead placed? I don't understand exactly.
Hmm?
Where's the ICD lead? Is it epicardial space? Just coily?
Yeah, is it posterior epicardal? So you're shocking from that coil to the box.
I don't think it's a traditional epicardial lead.
No, the old epicardial lead used to be patch.
Right.
Patch caused a lot of trouble because of erosions and many other things. So we used to put that coil in a Medtronic device in the coronary sinus. They learned that if you coil that curve long enough to cover the posterior wall, and then shock box is anterior, remember its configuration, you could deliver, they can defibrillate. So nobody uses a patch anymore these days.
So surgeons place the coil electrode just posterior wall over.
Yeah. Mm-hmm.
LV ventricle
Yes.
and fixed by suture.
No. You can only suture because the heart cannot be elevated. So they usually tie the where the curvature is, the proximal portion. Okay.
Then the
No,
lead
doesn't.
can
Doesn't.
displaced.
You put a
No.
transverse sinus below.
Oh,
Okay. Yeah.
oh.
Look at the left atrium posterior, right there junction. The key that the posterior wall, you see the coil going to the right to the left, not going to the left to the right. You see this in the
Yeah.
X-ray
Yes.
view. Yeah. That's why it's stabilized. Okay.
So in the coil is in the oblique sinus,
No, transverse sinus.
transverse
Yeah,
sinus.
transverse sinus. Yes. Because between the roof of left atrium below. So that way you shock a whole thing. Okay, look at the location. Much higher than typically pulmonary. Look at the bronchi, carina coming down, right? The bifurcation is almost the level of left superior pulmonary vein. Right, then you get the PA view. So left carina coming down, left bronchi, where you guys do PB isolation business. That's a coilis.
Then surgeons should dissect the membrane between the SVC and right superior pulmonary vein.
No, you
to
don't.
enter the transverse sinus.
No, you don't have to, because you follow the transverse sinus. You come down over the aortic before the aortic. You can come through the transverse sinus. You can go to the right, to the left. Yeah. Remember the pericardial
I
fold,
see.
like a C shape.
I see.
You go over.
Yeah.
That's what it is. We are going reverse. Yeah.
And anyway, he had the normal ejection fraction and the valve function is not bad. And after the admission, he still had the PVC and the Rusedepan events, and he has some he had repeated events. So this is end of my presentation, and I prepared short review before we end this discussion. And this is the first ECG I prepared.
So what was causing this patient T of alternates. What initiates any emotional or anything change? It looks like a long QT type 3, this patient.
I think so.
That's why you're getting maxillary.
Yeah.
Okay.
He
But
has
the-
bronchitis type 3.
Yeah.
Yeah.
All right. So, any particular trigger event that you have any constant history in this guy? Why such young patient having this stroke?
He originally he was taking mexiletin and nadolol.
Right.
However, mexiletin is was not produced
I see.
because of pharmacologic business.
Oh,
So
he dropped.
He had to
Stop. Okay.
stop the
Mhm.
mexiletin.
That makes
So
sense.
and then he polymorphic
Right.
QT very frequent after
Drop.
stopping the mexiletin.
Because the maxillary is one of those drugs that you guys cannot stop suddenly. This is something that you need to learn. Because if you go into the surgery, something like that, my old mentor used to tell, taper down rapidly. Because very strong sodium channel blocker, is sudden drop can cause all this electric imbalance, sort of repolarization, depolarization, whole 9 yards. That's why popularity of lidocaine infusion was very popular before.
Please, fellows, remember this QA morphology.
Right.
That's typical
Type 3.
QT morphology of the type 3 long QT.
After he took the mexiletin, the
Mhm.
polymorphic QT was controlled.
What do that?
However, 2 weeks later, he got influenza infection. So he had a
Fever and all that.
So, and then
Yeah.
so the same electric storm developed during the
Yeah.
high fever period. So we intubate and mechanical ventilation, and then
So he does have overlap behavior because early repolarization, the buccal as well, fever trigger CNA5A deficiency. And depending how much polymorphism you have, a mutation they have. So he does have a part of the overlap syndrome that this guy is not just pure long QT3. That makes sense. Otherwise, it would not be this crazy repolarization business.
In some patients, the long QT3 doesn't respond to beta block at all.
Right.
I have experience. So after putting ICD, I prescribed the beta blocker and the ICD storm. So after changing to mexiletin, patient is calmed down.
And the long QT3 patient, if they go to the surgery, some people even prophylactic lidocaine infusion before the surgery because of that. Suddenly, you can have an ICD shock and during after surgery, any kind of abdominal, whatever, you have to stop the medication. So that's something that you need to precautious think about it. Okay. You will have to dose of IV lidocaine infusion, some 1 milligram, half a milligram. You will be controlled throughout the surgery and then until reassume is Lexatil.
So, Dr. What is your future plan, long-term plan, how to manage this patient?
also the table.
Just wait for grow up.
Okay, I prepared the review from the Dr. Schwartz, which was at the New England Journal of Medicine last year.
Mm.
And so I will review quickly. So it's not that rare because it is more than 1 in 2,000 and leading cause of sudden death in young person. And it could be possibly underestimated because this number is based on the phenotype positive. I mean the prominent long QT patients. So there could be more genotype positive patients. And 3 major genes is already known. It accounts for 90% of the cases. And type 1 is the gene coding the slow rectifier. And so it is usually triggered by sympathetic tone increase, such as physical or emotional stress. And we know that swimming is most dangerous for type 1. And for type 2, the rapid rectifier is wrong, and sudden alarm, such as sudden noise, could trigger the event. And type 3 is actually gain of function of the sodium channel. And so this patient actually is dangerous when they are rest or sleep. And some other mutation is recurring, but it's not uncertain about those other genes. And as the rectifier has some functions, so usually the repolarization is presented at the T wave abnormality. So that's why I prepared the ECG that these broad-based T waves or T wave notches or biphasic T wave and T wave alterance or deep negative T waves or notched T waves. So some of them were noted in the previous ECG, and these are the dangerous signs that the repolarization is not going well in the patient, and so we should think about the long QT syndrome in this patient. And actually, there are diagnostic criteria suggested by Dr. Schwartz, and it is based on the QTC prolongation and also the Torsades points, and the T wave alterance and the notched T wave is also in the criteria. So we should note these signs in the ECG, and the syncope or the family history or unexamined sudden cardiac death in the family member should be also noted, and more than 3.5 points are diagnosed in long QT syndrome. And regarding the genetic test, Schwartz claims that the genetic screen may help the diagnosis, and also 24-hour Holter could unmask the long QT syndrome. And also, he claims the only useful test is the exercise test. He claims that the epinephrine test and tilt table test doesn't have much efficiency. And in the exercise test, the 4 minutes of recovery at the 4 minutes of recovery, marked QT prolongation is highly specific for long QT syndrome. And so for the therapy, the four cornerstone of the therapy is beta blocker, maxillatine, 그리고 left cardiac sympathetic innervation and the ICD implantation. And there are type-specific treatment. Usually the maxillatine is typically for the type 3, but there are some reports that type 2 also respond to the maxillatine. And LVFD and the ICD could be also considered, and beta blocker is the main therapeutic strategy. And so for the beta blockers, not all beta blockers have the same impact for the patients. Only 2 beta blockers has shown the efficiency, that is propranolol and nadolol, and it's not recommended to use the selective beta blocker. And also, time negative patient with the gene positive also should be prescribed with the beta blockers. And the left cardiac sympathetic innervation has a very strong experimental and clinical evidence. It has the antiviral effect. It also can shorten QTC in some patients. And after the LCSD, about 90% of the shock was decreased in the patients. And maxillatine is actually a sodium channel blocker. So based on the genetic mutation, type 3 is the gain of function of the sodium channel. So it originally has an effect in the type 3, but 70% of patients in type 2 also respond to the maxillatine. So we could consider maxillatine in type 2 or 3 patients. And the Schwartz claims that the ICD is overused in the long QT syndrome patient. He claims that when the 3 therapy beta blocker, maxillatine, and OCSD is used, then the ICD usage could be minimalized. And he claims that the cardiac arrest or the syncope during the beta blockers could be the indication of the ICD. And I also prepared the short review for about the guideline. In the guideline, the long QT syndrome could be diagnosed based on the pathologic mutation, irrespective of the QT duration. And guideline also says the routine diagnostic testing with epinephrine challenge is not recommended. And guidelines say that the beta blockers, ideally non-selective beta blockers, such as nadolol and propranolol, should be used. And mexiletine is just stated for the long QT syndrome type 3. And also the pathogenic mutation without QTC prolongation also needs some beta blockers in class 2A indication. And in the guideline, the ICD implementation is recommended as 2B when the patient has a high risk profile for the asymptomatic lung QT syndrome without any cardiac death, aborted cardiac death or the syncope, but the recommendation state is 2B. And also invasive EP study is not recommended for the lung QT syndrome. So this is end of my presentation.
Okay. Very nice summary. The last question, maybe, when will you replace epicardial IST to transvenous for this poor child?
Yeah, body weight is body weight more than 20 kilograms. Yeah, we can implant transvenous.
And do we need to remove the epicardial?
Probably
Just a
yes.
little bit?
Probably
You take a
yeah, we
general
need
out,
to, yeah, we
leave
need
the
to,
wires.
remove the transvenous ICT.
But it is this, we need to treat the retained lead like transvenous lead, same,
Right.
no MRI.
No, no, right.
So
And
20 kilogram.
Usually now they used to be 35 kilogram, but then now technology involves so much. Our leader got thinner, smaller, and the generator also smaller. And so you can do either transvenous, either you can do prefectorial, sometimes abdominal, you can tunnel. But I think these days, retrofectorial young child, pre-chest would be probably reasonably good approach now. Because the IC generator is such a small now, slightly bigger than pacemaker these days. So technology improved remarkably in the last 20 years.
Okay, thank you very much.
EP Fellow at Severance Hospital from Kashmir, India. LP today presenting the EGM conference.
Please, the loud speaker.
So the patient I'm discussing today is a 14-year-old boy who complained of palpitations 2 years back in August 2024. The palpitations were sudden in onset and offset. There was no similar family history. And at an outside hospital, the tachycardia was terminated by verapamil. This was the tachycardia ECG in August 2024. I will give you some time to have a look on this ECG. He underwent radiofrequency ablation here in February 2025, but he had recurrence of same tachycardia in September 2025, one episode, and he was put on PR verapamil. He had 2 more episodes in October 2025, and then he was planned for a redo. This was the ECG in September when he had a recurrence. I'll again give you some time to have a look at this ECG. So he was taken on January 7th for a redo EP study and possible RFA. And this was his baseline in January ECG. The chest X-ray was normal. The echocardiogram was also normal. So he was taken for study on 7th of January. This was the baseline catheter. So we put a CS catheter and an RVHIS catheter. This is how we started. These are the baseline intervals. He has a baseline HV of 34 milliseconds. we did the usual stimulation protocols. The AV block cycle length was 360 milliseconds. The AV node ERP was 600 by 280, and AERP was 600 by 200. When we started RV pacing, a tachycardia was induced at an RV straight pacing cycle length of 320. This is the tachycardia surface ECG, which resembled the clinical tachycardia. The tachycardia cycle length was around 330, and QRS duration was 123 beats per milliseconds. The RV, this tachycardia could be entrained, and we demonstrated progressive fusion at cycle lengths of 300, 290, 280. But the PPI minus TCL was long from RV. It was around 85 milliseconds. And before I come to that, I forgot to mention that this tachycardia, the intracardiacs of this tachycardia clearly show a weird association with more V's than A's, proving that it's a ventricular tachycardia. We tried to entrain this tachycardia from CS910 atrial pacing, but with repeated attempts, we could not show entrainment from the atria. At this point of time, we took an arterial puncture and introduced a linear multipolar catheter, the Nogami catheter, in the LV with these electrodes lined up on the septum and these 4 distal electrodes at the LV apex. So in these are the this is the LV septal activation pattern in sinus rhythm. This is at a higher speed. The numbers are here wrong. They should be numbered 5 to 6 to 14, but perhaps at that point of time, the numbering was not updated. So the LV septal pattern in sinus rhythm is from base to apex. And with LV pacing also, we could induce the same tachycardia. This is the surface ECG. So in this tracing, there's an interesting tracing that there's a spontaneous induction of the tachycardia. We can see an AHV sinus beat, and then we can see the tachycardia going on, and the ventricular tachycardia HV was negative. And how much the HV is also gives us an idea of where this where the likely site of ablation could be from base to apex. There's a paper on it by Ma et al. In 2017 circulation. So this is the LV septal activation pattern during VT. I can show it at a higher speed with from an apex to base. What we call the P2 activation is from apex to base, which is the reverse of sinus rhythm. We could entrain this tachycardia from the LV, and the PPI TCL was short, 15 milliseconds. At this point of time, we did a septal puncture and introduced an HD grid for detailed mapping. This again, these are the intracardiacs with grid inside and induction with LV pacing. The induction in this patient was always easy, and throughout the protocol, ISO was not needed to induce the tachycardia. And at one point of time, we could note these 2 potentials in the grid, but not in other catheters, which is understandable given the high resolution of the grid and the smaller electrode spacing. And this is the P1, and this is the P2. And we completed the activation map using 3D mapping. And this was the earliest exit site, the white dot. This was the exit site of. So this tachycardia, though re-entrant, looks like a focal on 3D mapping. The earliest P1 to QRS duration was 46 milliseconds, which is meaningful also by the same paper, Ma et al., to show where the likely source of site of ablation, successful site of ablation would be. And we chose the earliest P1 as the site of ablation, which is slightly upstream from the ventricular exit site. And we know from multiple papers that the ventricular exit site, although may show a QS in unipolar, is not a good site because this P1, this most distal P1 or the earliest P2 is the preferred site for ablation. And this was the ablation site. We could not record a P1 on the ablation catheter, but it was annotated with the 3D mapping. The ablation catheter is a very crude catheter with a long, huge footprint, and we not record the small, fine potentials. And this was the fluoro wire it was, if we see from the base to apex, it was around here, and this is in the LAO. And to our delight, the tachycardia terminated in the first RF with no PVC and a clean termination. And we gave additional burns in the, in this area to consolidate our ablation. And these were the final ablation points. And the tachycardia was not inducible with aggressive programmed electrical stimulation with RV pacing, LV pacing. And this was the final EGM. And this was the post-ablation ECG. I thank Dr. Baum for this beautifully done case. And this is a lake from the Kashmir, famous lake.
Using palm.
Yes. Thank you so much.
Tell me something. What type of tachycardia this is? Where's it coming from? Particular DT that we see. Hopefully you're not telling me this is particular DT. Where is this thing coming from? Have any idea? Because when you said that there's a P1, P2, only every other bit, not every single bit.
Okay.
Just slide you there to
Right.
show the tracing. You said there's a P1, P2 business. I see only every other bit. Not this, so you can see there's a P1.
You
Sure,
mark the
every other
P1 and P2.
Yeah.
Yeah.
You see in every other bit. P2, I can see consistent fascicular activation. But what bothers me here most is that if you look at the LB34, activation time is the same. And, you rest the mapping catheter. You see it?
Mm-hmm.
And then importantly, more important that the LV5 and 6 R wave is a positive, 3, 4 is a negative, almost same time. Assuming that if you look at the configuration of your catheter, your LV 1, 2, 3, 4, and then big huge space 5, 6, Rogami catheter. All right.
Right.
So that's a huge area. That area which no electrode is coming this thing, breaking through.
Right.
In other words, 5, 6 impulse coming at it, 3, 4 is going away. That means between 2. But that's a huge area.
Mm-hmm.
And when you look at the 3D map, you're below the both papillary muscle. Show me the 3D mapping. I'll tell you. This view, you see the indentation in the superior inferior,
Right.
that's anterior posterior papillary muscle, pinching the ventricle.
Mm-hmm.
Okay, when you look at the 3D, always look for.
Mm-hmm.
And then this is below the papillary muscle, and then there's a subtotal. Clearly, yes, I agree. But I don't see that beautiful, distinctive P1 potential consistently every bit.
Mm-hmm.
So it's very hard to argue this is the true fascicular VT. Okay.
Okay.
Unless we missed P1 potential during the mapping, and accidentally you just got it ablated. So I think this is something that we have to think about a little bit more. So, and then also QRS morphology is not a typical fascicular VT. Look at the total DCG. If you look at it. So VT morphology, take a look. You have a clinical VT? Yeah. You think it is a typical fascicular VT?
It's slightly wider.
So it's a little bit wider in lead 2 than you like to see.
Mm-hmm.
Okay. So does ADR. So it is. I wonder whether this is not a, just coming near the close of fascicle. but also notching the 2 and 3 really bothers me.
Can it,
They're notching the whole thing is a QRS complex.
can that be due to previous ablation?
I don't think it is. Because even though you have the scar, your voltage map, and I should have showed that.
Mhm.
Yeah. I don't know where they ablated previous ablation, but it's something that you need to look for a little more carefully. And did you have any entrainment done during the tachycardia?
Yes, both from RV and LV.
No, but ablation site during the tachycardia, did they entrain from there?
Ablation site?
Yeah.
No.
Because typically, if you have fascicular VT P1, P2 present, if you entrain, you should be able to see the P1, P2 returns.
We
You
entrained
measure that,
from
yeah.
LV78.
And again, you don't see in your mapping catheter LV or what. Some of them shows a fascicular potential coming going. It's not a really steady potential that we can say I relate this particular VT. So I wonder whether this is coming from some sort of a trabeculation or tendons. This one's coming.
Yeah, we did not have ice.
You didn't have ice. Yeah.
Mm.
Because if you look at again far field signal, this one now, polarization reversing between 7 and 8, and then the 5 and 6. You see that?
Mm-hmm.
And then 7 and 8, very small notching perhaps you imagining there, but actually earliest far field, the 5, 6 is earlier. Yeah.
Mm-hmm.
Negative Q.
That's an interesting observation.
Yeah, we probably need to review the tracing a little bit better. This one.
Mm-hmm.
So, but appears to be not a reactant tachycardia. Looking at the activation sequence and morphology-wise, maybe the focal tachycardia from.
It was in train.
It was in train.
Okay. Yeah, but it is that is a trouble I think we see. Progressive fusion, all that people argue about this has always been in train. But you have to imagine if you have a structure that quadridimensional inside the ventricular cavity, trabeculation, things like that, you may be able to entrain because it's edging out toward the almost like tachycardia circuit. You have to remember that model. So many tracing that showing us to that even particular VT, as you know, we brought duodeca catheter 2 millimeter spacing along the line, and you pace every electrode. The area perfect match is almost none, 95% perhaps, very small electrode spacing. And you pace from there, actually, you cannot entrain. Majority of the case we done so far. So I am concerned that this statement of a fascicular VT entrainment in general is reentry. I may need to revisit. This is not a behavior that we see. And only moving a few millimeter away to the septum, you can have perfect match, almost like a pacing at the site of the VT circuit. So if there is, they get very small micro entry or either focal tachycardia behavior. Most of the case. Now, structural heart is VT, yes, fascicular VT is a reentry. We can train along all the fashion. We've seen that. So I think a Patrick Chu description early days of fascicular VT, which he had a post-MI VT, fascicular VT different than what we're dealing here, normal heart.
Mm-hmm.
There is something that we are still missing. So latest hypothesis of that, the people proposing that near the posterior fascicle, there is a tendon or either thick muscle bundle trabeculation that causing T1, T2 issue.
Mm-hmm.
There's some latest article came out. That is also has a merit, but we don't really see intracardiac echo that structure, unfortunately. So think about this, what I'm telling you.
Yes.
I don't know answers out yet. So that's why they can just have so many variants. Posterior papillary muscle like a fascicular VT, all these things. So I think there's no uniform hypothesis what actually this means. But it is truly Purkinje natural system tachycardia. Agree? The question is that there's a fascicle or is it Purkinje bilateral junction tachycardia like a CTVT that we know now? Who knows? So hopefully you guys can give us an answer.
Yeah, still I have a lot of question about the mechanism
Right.
of vascular VT. Even though we are familiar to the P1, P2 potential, every textbook and the review article shows that example.
Right.
But we saw in the Cambodia,
Right.
sometimes there are those sharp Purkinje-like potentials and bystander. right? So nearby the reentrant circuit, we can see the P1, P2 potential comes and goes. So sometimes we saw the dissociated Purkinje potential during the ongoing tachycardia. So I think it's reasonable to think the Purkinje system is everywhere in every people. You have, I have, right? But some patients make both suffer from this kind of tachycardia, but some patient does not. So Dr. Nogami's hypothesis, Dr. Huang's hypothesis is really genetic background or the focal inflammatory result. Probably there's some pathology. So please keep in mind, of course, you have to keep the rule written in textbook and review. Try to look for the P1, P2 potential, but sometimes it is not the real answer. We see some epiphenomenon.
I have a biggest problem Nogami initial classical P1, P2 figure. You look at carefully. P1 potential EGM characteristic compared to P2. First of all, frequency P1 much broad, more like a far field, a low frequency signal. P2 very sharp.
Sure.
So you wonder that I can record many times when I touch the circulation peritesticular muscle. I can record those signals. Sometimes your bubble motion can create that. So I wonder whether he's recording along this hypothetical tuberculated tendon along the line inside which it contains Purkinje fiber, which can perfectly make sense with activation inserting into the P2. So question though, is this a truly mechanistic involvement of the tachycardia circuit? I try to entrain P1 every case if I can. Doesn't work. I haven't been able to do successfully entrain from P1 potential tachycardia circuit. And perfect entrainment, I have not been able to do that. So you do have, Dr. Bach says, in our series, we have a 47 case in Myanmar right now, circular VT. We look at every case, and then you pace from junction P1, P2. Yes, you can entrain close, but not perfect. Only very few patients are perfect. But the P1 itself, not able to, not yet. And then we only find the P1, not everyone, about 30 to 35% of cases from Myanmar. So we're analyzing data right now. So it's very interesting.
Can I see the slide, the P1?
Yeah, actually, if you look at the P1, P2 here, 13, 14, 15, 16, 14, 15, activation sequence is reversed. Do you see it?
Dr. Wang,
Yes.
if you open your mind,
Yeah.
is there some pop field?
I don't think so. No. Because look at your frequency level you're recording P1, P2 in the bit that you have. The second thing is that P1 itself, not stable. Look at the next bit. EGM. Timing is slightly different. That bothers me quite a bit. If it is a P1, P2, you have a constant relationship between P1 and P2.
That could be bystander.
Yes, that's what I did. Yeah. That's why I don't think that's a P1. What the Nogami referring. Nogami's his paper says one-to-one relationship. That's what troubles me so much that I've been looking this for a long time now. So if you look at the
That
first
was his best example.
no. Look at the first bit, third bit, fifth bit, seventh bit. There's a P1 like a structure. Yes, I agree. That might be my kind of Purkinje junction. Yes, I can believe that. But I'm not sure that's a P1 or P2 business. Like Nogami said, along the line propagation and then beautiful type solid P1. I'm looking still for that step.
Dr. Nogami also agreed this hypothesis.
Yeah, I think so.
No proof.
Yeah, no proof. So when you read the paper, just look at the signal frequency and then also EGM characteristic. Okay. So we say that's a particular P1, whatever. You should have at least a similar frequency of signal. That's, I think, the important concept. Okay. Okay.
One more thing is when you do 3D map with HD grid catheter, this kind of vascular VT cases, it's better to tag all the vascular potential area. Sometimes you ablate the posterior vesicle, but the tachycardia change morphology to anterior vesicle. Sometimes intervascular VT. So if you tag the location of the fascicles before during mapping, it is very useful to find the second.
Other elegant way was best way to do this is that you only map the Purkinje potential one map.
Mm.
Next, you map only the marker activation. Then you try to over. This is particularly useful if you try to ablate the PVC from close the conduction system, not to cause a heart block. Okay? Because you can look at the activation of myocardium versus the Purkinje activation, you overlap. And then whatever that coincides earlier spot, that is the way you're going to ablate. And your number of ablations reduces quite a bit.
Mm.
And you don't have to open all over the place.
Actually, you don't have to map twice.
You map twice.
Yeah, because there's a turbo map function.
Right,
in
that's a
the
new one.
system.
Right.
If you give the street mapper 5 or 10 minutes,
They
they
can
readjust
right.
the gating
Yeah.
and make 2 different maps.
We did propagation PVC the other day in another hospital, and we had to map twice because with very close to his bundle, we didn't want to cause heart block. So we did that, and then we got away. So PVC, paraxet PVC, very close to his bundle. So there's sometimes trick that you need to think what you want to do with the map.
I just assumed that this was a recording problem, but there are new insights about it may be mechanistic.
Right. That is a very interesting case. Yes.
Thank you.
Thank you. Hey, now Professor, again, gonna give us a lecture. Oh.
Okay, I hope this lecture might be relevant to today's case. I prepared diagnosis and ablation strategy for vascular VT. So this is the classical diagnostic criteria of the vascular VT. According to Zipes, it should be induced with atrial pacing, an LV pattern with the left axis configuration, and there should be no structural heart disease. And Bell Hassan added one more thing. It should be sensitive to verapamil. And Dr. Owe added some variants, RBBB with the right axis deviation. So this is the Logami's beautiful review paper. He classified the Purkinje-related arrhythmias like 6 components. One is the typical thing we imagine the anterior or posterior type of vascular VT. And number 2 is the intervascular VT between anterior and posterior fascicle. And he also emphasized the V-feed trigger from the Purkinje and upper septal type vascular VT. And nowadays, they all many emphasize, he has been emphasizing regarding this intramural Purkinje muscle junction and denaturating for VF suppression. So this is the EGM and some examples. And the left posterior type vascular VT might be the most frequent one, 7 to 80% of the types, and left anterior type vascular VT, and left posterior type vascular VT, but it is reverse type. The anterior and antegrade and retrograde is reversed, and maybe 5% of the patient has some upper septal vascular VT, and this is the tracing, but still there is some unserved part. Usually these only diastolic part we cannot recall the EGM during this early diastolic period. So this red period is matched with this type in anterior fascicle, posterior fascicle, or reversed or upper septal fascicle. And Dr. Komatsu subdivided our typical posterior or anterior fascicle VT into septal or papillary muscle subtypes, and there are some tendency of lower sensitivity verapamil in patients with papillary muscle subtype vascular VT, and ECG can be a little bit different. Number one is the usual septal posterior vascular type, left axis deviation. But if the patient has some papillary muscle type, the AVL, it's negative, so it's a little bit northwest axis. And for the anterior vascular types, the septal type has some big R, but papillary muscle type has some small R and deep S in the ECG findings. Actually, it's not. Firstly, the Dr. Komachi is not the first to explain such kinds of distal Purkinje muscle reentry. Hasegaer also presented some his Purkinje VT schema, bundle branch reentry between two bundle branch and our vascular VT, and there can be some distal Purkinje muscle reentry like this. So this is the classic schema. The entrance site, the P1 to slow zone is located at the base of the left septum, and P1 might be some dull and low frequency potential appear a little bit earlier, 30 to 130 milliseconds earlier before flawless onset. And exit site is the located in the infero-posterior left septum closer to the apex. And the P2 potential tends to be a high frequency potential. It's slightly earlier, 15 to 42 milliseconds before QRS onset like this. So this is the landmark study by Dr. Nogami. This study made some paradigm shift in ablation targeting from ablating just pre-systolic vascular or protein potential like P2 potential to ablating mid-diastolic potential, some kind of crucial potential confirmed by entrainment. So this paradigm shift shifted from targeting single fused P2 to double potential P1 and P2 junction. This is the evidence. In this case, the P1 also dramatically captured when he delivered the pace. And this kind of P1 potential was observed in 75% of the patients, but our P2 potential was observed only in 25% of the patients. And this is the P2 potential in controversy. The VT was going on. There was some sinus beat. And the P2, the wavefront of the P2 changed, but there was no change in the VT cyclings in this patient. So this is against evidence of the P2 engagement in such kind of VT. And in this panel, the VT was perfectly entrained from the LV myocardium. It was perfectly same with the VT cyclings, but seemed to P2 potential was not that perfectly matched with the VT cyclings. And the third panel, it delivered ablation and P2 sequence changed, but there was no change in the VT cyclings and P1 sequence. So the for capturing P1 potential using first deflection annotation, we can make some adjust to the window period. Oh, the At least the P1 potential might be some entrance site or some kind of proximal bystander like this, because the earliest P1 potential might be recorded around here. So our conventional ideal ablation site was actually the P1 and P2 junction. But in reality, there is still the problem is the frequently there are lacks of detectable P1 because due to the limitation of the ablation catheter because it has larger electrode and larger interspacing full mapping. So in this decoupler catheter, the P1 potential was observed, but there was no the ablation catheter was placed in the just next to the decoupler catheter, but there was no P1 potential on the ablation catheter. And P1 might be too short on all non-parallel. So if the P1 is too short, unusually, and if the P1 potential is perpendicular to the left posterior fascicle, then sometimes we cannot observe the P1 potentials. And the third reason of the lack of detectable P1, and P1 might be sometimes subendocardial on intramural reentry. So this is the post-MI Purkinje-Merit V2 case. There is some U-shaped line of block suggesting the wavefront go into the deeper tissue and come around. So also for this kind of Purkinje Mosul junction, there might be some 3D circuit, like Dr. Nishimura's paper for VT cases about hyperboloid circuit. And so nowadays, also Dr. Chonwang always recommended to read this paper from the UC San Francisco, and there was some emphasis on the septal fascicle, and the septal fascicle has some extensive branching and the sourcing mismatch, and it can facilitate both conduction slowing and circuitous lengths of conduction. So this kind of diastolic conduction through a Byzantine septal fascicular network would it might be not recorded our linear catheter. So our observed potential might be a coalescence of the septal fascicular fibers into a bundle if and connect with the left posterior fascicle that is a sufficient size and orientation. So this previous unserved section of the slow conduction might be retrograde conduction through this kind of serpentine septal fascicular network. So in our also today's case, always reality, our 3D map shows like centrifugal activation from apex, the exit side, and centrifugally going to the base. So we cannot certain about ablation target using this kind of centrifugal exit site mapping. So to ablate for the ablation target, at least activation of the LV myocardium, or at least activation of the P2 potential. If you use some high density map, and in this paper, they used some grid catheter. They use manual annotation of the low frequency, low amplitude signals and targeting this kind of septal fascicle. So this is the usual centrifugal map. But manually annotate, we can map the kind of this fascicular-like potential. It's actually from base to the apex. So successful ablation target was the based on the here PN recording area and ablation catheter at the success site could not, but ablation catheter in this case also could not detect the PN potential. So this is maybe this case from Dr. Park, right? And it was the Tradu vascular VT, and previous 2 sessions were from our hospital. It's like really narrow VT and ECG. And this is sinus rhythm, and this is the VT, almost same axis and just our BBB and narrow QRS. So we performed the intravascular area entrainment. It was the only 5 milliseconds difference. Posterior vascular also. And at the occipital vascular, a little bit basal side, the PPI minus TCL just 1 in this case, and perfectly matched. The QRS morphology was perfectly matched in this case. So this is the mapping. Still, it looks centrifugal. And he makes some dots on the site where the vascular potential was recorded. And if we did some adjustment to map only the vascular like potential manually, in this case, in this map, and we can see it going up and going down. It's actually the almost same with the occipital vascular VT by Voltage of Dr. Nogami. And the septal vascular is going up retrogradely and going down using the anterior and posterior vascular. So the successful ovulation site was the just turnaround site of the septal vascular. And the chelation was terminated and there was no induction after the ablation. To summarize my talk, diastolic P1 potential has been emphasized due to, and it might be associated with septal vascular network, and sometimes associate the papillary muscle or first tendon due to limitation of our larger electrode catheter, and sometimes the fiber might be too short or non-parallel, and sometimes the fiber might be located in the deep intramurally. There might be some Purkinje muscle junction. So using some kind of small electrode and smaller spacing catheter might be the feasible alternative. And if still P1 potential cannot be recorded our current technology, then first thing to do is to confirm the correct diagnosis is kind of vascular VT, like Dr. Hwang Jun also emphasized today. So non-reentrant vascular VT should be considered. It typically responds to the lidocaine beta blocker. And after reconfirming the diagnosis, targeting the least ventricular activity with the fused P1 might be some alternative. And if V1 VT is inducible, and also although P2 might be a bystander, this strategy may be successful if the site is adjacent and just nearby proximity to the point of P1 P2 connection. And also sometimes we can use some anatomical approach by Dr. Tara and Talib, and we can define the axis site by pace mapping. Usually, in this case, VT is not inducible easily. So define the axis site by pace mapping, and linear lesions create some block across the estimated T1 tissue. And sometimes you can confirm the effect of ablation on P1 tissue by observing the P1 appearing suddenly after the QRS complex. In like this case, P1 is really delayed after the ablation. Actually, after ablation and after verapamil injection, the P1 is more delayed, proving this kind of potential is sensitive to the verapamil, and we did something by ablation in this P1 tissue. Thank you for your attention.
Thank you very much. Questions from fellows?
민나요나는 에그 맹먹 베이컨 에그 맹먹
I don't have any.
Was it perfect lecture?
It was understandable, yes.
Dr. Kim,
Yep.
can you tell us a little more about the Purkinje VF?
Purkinje VF?
How does it differ from vascular VT?
Oh, it's VT and VF? Wow, it's two.
Honestly, I never been experienced to ablate the vascular Purkinje VF, but in the international conference, a few people insist that we can ablate VF by
Right.
ablation.
Actually, Dr. Dogami last week delivered some speech and lecture regarding the Purkinje VF, and there is some paper from the Dr. Komatsu about regarding the difference between Purkinje trigger and the myocardial trigger triggering VF. So maybe next time I can prepare and talk.
I think primary VF from the Purkinje, you should see isolated PVC coming from the Purkinje fiber, like a fascicular PVC. And then typically they will do long shot typically, and then start firing, and then you get polymorphic VT to VF back and forward. We have about 4 cases done. But actually, if you map that PVC itself or non-sustained VT with the high density mapping, we did it with the Orion, we did it with the grid, you can see pre-potential fascicle that trigger PVC activate like 3-4 times faster than your myocardial activation. So you have a bunch of area that's spreading Purkinje network. So we learned that also that if you just ablate a focus, you fail, because we don't know how deep that Purkinje goes in that endocardial activation. So you virtually have to ablate all this first few seconds of non-sustained, at least a couple of feet Purkinje fiber area. You tag all of them, try to ablate all of them. So you're ablating actually area, you're not ablating one focus. Michel, last time I talked to him, he also feels that's the probably way to do it, not just the, which is a completely different than on the right ventricle PVC trigger VF, which is a different mechanism of PVC. And they still cannot explain why the RVOT PVC, infundibular PVC, can cause a VF. I don't think they have any Purkinje potential involved on that. So I think the answer is not in. But LV septal PVC trigger primary VF, you can ablate it, but then require a lot of work. You need to well document the PVC, and then you can do it. But sometimes patients have a frequent PVC take to the lab, suddenly no PVC. Other issue that I have debating most is that we have a patient with primary VF, we did not ablate. We just put ICD on the guys. They don't have episode for 10 years after the first storm. Then you wonder what to do with them. This is a major clinical issue that we have to answer. So the question is, do we really need to ablate this primary VF business or not? That answer is one. We don't know that. Number two, who to ablate, who to not ablate. And number three, what do we do 10-year follow-up no VF episode? Do we take ICD out? Do we keep the ICD in? Because this is very young people. We're talking 20, 30 years old people, very active. So actually, there's one patient I had example. They brought me a court order to remove the ICD. I refused to remove ICD. I went to the court. judge signed, take it off. That's it. That extreme can happen because ICD is not easy to carry around a reversible light. So I think we still don't know many things about this business. So
I think the management of this, the ventricular fibrillation will also be polarized.
Right.
So single arm is
Right.
AI ECG guided prediction. The other one, pulse field bombing.
Yes. So I think issue that first of all, we need to know a little bit about the natural history of disease before we can make all these decisions. I don't think not knowing the history, I think is very difficult to even conjecture or propose a treatment, and it's a very difficult clinical issue. And I have a very bad experience both sides. So.
Okay, Dr. Kim, will you give us a second lecture next weekend?
About what?
Cooking the beer.
Yeah, wow.
Okay, later time. Just kidding. Okay, thank you very much.
All right, have a good day. Thank you.
Have a nice
Thank
weekend.
you.
Bye.